Good afternoon, everybody. My name is Victoria Lancey, and I'm the Rural Education Manager with Michigan Center for Rural Health, and I will be facilitating today's program. I would like to welcome everybody to today's Pharmacy Grand Round on over-the-counter access to oral contraceptives. Before we begin the program, just a couple reminders. If you are logged into the webinar portion and have computer speakers, you can listen to the audio through them. If you are listening to the program via just the audio number, handouts are located on our website for you to follow along. Our website is www.mcrh.msu.edu. Click on the education link on your left, scroll down, find the Pharmacy Grand Round, find today's date, and there you will see the presentation, the attendance form, and the evaluation link. Attendance forms and the evaluation link need to be filled out, and then the attendance forms need to be emailed, faxed, or mailed into the Michigan Center for Rural Health office within 2 weeks or by August 5th. If you would like to ask a question during the program, please type it into the chat box, and so you don't forget it, and the presenter will address it during the Q&A portion. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I'm pleased to introduce our speaker, Dr. Teresa Bailey. She is a professor at Bear State University College of Pharmacy, and her clinical practice sites are Western Medicine Cerebral Palsy Clinic and ProMed Family Practice. She has given many presentations on dietary supplements, women's health, and ambulatory care topics at various audiences, that include healthcare providers and patients. She is board certified in pharmacotherapy and ambulatory care. With that, I will turn it over to our presenter, Dr. Bailey.
Thank you, Victoria. I'm hoping everybody can hear me. Otherwise, let me quickly check and make sure that no one's raising their hand if they cannot hear. Okay, I don't see anything, so I'm assuming yes, it's good to go. Okay, so today what I want to talk about is over-the-counter access to oral contraceptives. Let's see if I can move the slides. Okay, so the objectives that I want to talk about are going over so that you can recognize side effects of a combination oral contraceptive, but particularly being able to recognize if it's a side effect due to the estrogen component or to the progestin component, and then also recognize potential drug interactions with oral contraceptives, and then lastly, be able to summarize or explain to a patient what are the advantages and disadvantages to oral contraceptives. So why did I pick this topic, or why are we talking about this topic, is probably the key article that was published a couple of years ago that kind of triggered all of this was back in December 2012, and this is from the ACOG group, or the American College of Obstetricians and Gynecologists, and they created a committee and talked about whether or not over-the-counter access to oral contraceptives was a valid issue to pursue and discuss. And out of that meeting, the ACOG group said, yes, this is definitely something that needs to be pursued in the United States or worldwide, because then it will actually give women more, greater access and use to birth control, and also hopefully decrease the unintended pregnancy rates. They also, in the statement, said that there are some concerns that we're going to have to face, and I circled the red right here because the first one that they listed is payment for pharmacy services, and I thought that was a really awesome thing that was listed as number one in the summary, because so many times as pharmacists we offer services and we don't get paid, and so this is an area where physicians are going to help us pursue payment for the pharmacy services when we offer over-the-counter access to oral contraceptives. Secondly, the other concern that they mentioned, which is always a concern when medications go over the counter, is that insurance companies, for the majority of the insurance companies, they will no longer cover or pay for medications that were once prescription and then moved over to over-the-counter status. And then the last thing that they listed is the possibility of pharmacists inappropriately refusing to provide oral contraceptives. And that's what I want to spend some time today, is talking about that we would feel comfortable being able to screen these patients and decide which ones would be candidates to use over-the-counter oral contraceptives or other hormonal options, so that we are more knowledgeable, so that hopefully we're not refusing patients just because of the lack of knowledge that we have. So the first slide here is a picture of the United States, and this is taken from the LA Times, and this was published in April of this year. And it was an article describing how California is the third state that actually has approved over-the-counter access of birth control pills, or hormonal contraception, I should say, without a doctor's prescription. So in California, and you can see the other two states that are in orange are Washington and Oregon, and then Washington, D.C. is also part of that small group that has started, where pharmacists are allowed to dispense oral contraceptives, but also other hormonal options. You can also see on this slide that the pale yellow are states that actually are in the process of getting pharmacy or pharmacists over-the-counter access to birth control, and they're in process right now. You can see, you know, our mitten in the United States, or Michigan, we definitely still are at the status of where doctors have to write a prescription. But, you know, looking at past opportunities that pharmacists have had, and it's the first one that comes to my mind, is immunization status. One by one, each state actually added or created legislature to pass that pharmacists could bill and administer vaccines. And so my guess and my thought is that eventually all these states will be orange. It just is a matter of time. And that one by one, each state will look at other past states' legislator, tweak those, change those, modify those to fit the individual state's needs, and then pass those. So if I had to take a guess, I would guess that in, you know, 10 years or less, Michigan's going to be one of those states that pharmacists will be able to dispense birth control without a prescription. So with that, what I wanted to do is take a look at California's new birth control law. Again, this is still taken from the LA Times, and there's the website if you wanted to look at it more in detail. But the one thing that really caught my interest was it was a question and answer geared toward patients of what you need to know about California's new birth control law. And so I took some of it just to get an idea of what, because I think other states are going to look to the past three states to see what things have they approved and what the process and any concerns or problems that raise. So the first thing that we should probably be aware of is what kind of birth control can a woman get in the state of California? And this is specifically California, since this is the most recent. So California law covers self-administered hormonal birth control pills. So it covers the pills, but not only the pills. It also covers patches like the Ortho Evra patch. It also covers injections like Depo-Provera, and also the vaginal rings like NuvaRing. So when I first read about the ACOG statement, I thought it was just going to only be birth control pills. But it depends on the state, and it could be a variety of hormonal birth control pills. So today we're going to review each of those just so we feel more comfortable talking to patients and assessing patients whether or not each of these products would be a candidate for them. Now, luckily in California, and I'm guessing every state, that one of the exceptions is going to be that pharmacists are not going to need to insert anything. And so thank goodness we are not going to have to insert any IUDs. I'm pretty sure that every state is going to have that in the law. And then the one thing that I think is going to change depending on each state is if there's a minimum age. And so in California, the question was, does the woman have to be a certain age? And in California, there is no minimum age. My guess is that each state is going to either have no minimum age or 17, 18, whatever. They're going to have their own individual depending on their state's needs. So then what, if we were to go into a California pharmacy as a patient, what would happen at that pharmacy? The first thing that would happen is the pharmacist would take the blood pressure. And that's to make sure that the person doesn't have uncontrolled blood pressure, because then we're just not even going to even go down the road of any hormonal contraceptive for the most part. So I guess it's a heads up if you're not very proficient about taking blood pressure with a stethoscope, then you might want to practice that on some of your friends. Or, you know, I'm guessing some of the pharmacies are going to purchase an automatic blood pressure cuff that would accurately take a blood pressure to make sure that the person doesn't have uncontrolled hypertension. Then the next step would be that the woman would fill out a questionnaire. And the questionnaire summarizes all the variety of different contraindications that you want to make sure that this patient does not have if you're going to dispense a hormonal product. So the questionnaire consists of, does the female, has she ever had a heart attack? Has she ever had a stroke? Has she ever had a history of past or present breast cancer, cervical cancer? What medications is she on? Because there's some drug interactions that we're going to talk about. Does she have uncontrolled hypertension? Does she have migraines, and so on? And based on those questions that the female fills out, then we'll be able to assess whether or not she's a good candidate to have over-the-counter hormonal contraceptives. So then the other thing that I think is interesting is at this point, then if we as pharmacists feel comfortable saying, yes, we can dispense a hormonal contraceptive, then between the female, she could ask for a certain kind of birth control, or the pharmacist can recommend one. And my guess is that how the wording is in this article is probably not necessarily that the female's going to be like, I'm going to want the hormonal patch, and the pharmacist is going to say, no, I think you need to have pills. I think it's probably going to be more of a joint effort of discussing the pros and cons, or the advantages or disadvantages to each of these products, so that the female can make an educated decision based on the pharmacist's knowledge and help making that. So then at that visit, there's going to be a required patient education. So we are going to need to know how to explain to a patient how the medication works, how to take it, what potential side effects are they going to look for. We're also going to need to recommend or also educate the patient of how important it is to still have those health screenings, such as for cervical cancer and breast cancer, because remember, they're going to bypass their physician in order to get the hormonal contraceptive, but they're still going to need those health screenings on, you know, a periodic or a regular basis, depending on what age they are, if it's a yearly or every 3 years or so on. And so we don't want them to miss out on that. And then all of these products that we're going to talk about today, they offer no protection of STIs or STDs. And so if that is a concern for a female, if she's not in a monogamous relationship, then we still need to educate her on using a condom for that protection. And then each state creates their own birth control fact sheet. And the fact sheet pretty much includes all of this required patient education in, I think, a 6th grade education reading level, so that then that fact sheet will be sent home with the patient to be able to refer to later on. Okay, so now that we have a heads up of what potentially we could be seeing in the next couple of years in Michigan, what I want to do is spend some time and talk about some of the birth control methods on this slide, but not all of them. I want to focus on the pills, obviously, since they are in the center of this picture, but they pretty much are the center of what we use as birth control. And then also cover a little bit about the patch or Ortho-Evra, also cover the vaginal ring, NuvaRing, and then also lastly cover the injectable or Depo-Provera, because I could potentially see where we could easily administer that either intramuscularly or subcutaneously, because it would be very similar to an immunization injection. So first, let's talk about the mechanism of action of how we're going to explain this to a patient. And first, I think let's review it so that we remember how it works. Remember, in most products, there's a combination. There's an estrogen component and a progestin component. And the estrogen component is primarily, it inhibits the follicle-stimulating hormone. And so what that does is it blocks that hormone from releasing many follicles or eggs. And so eventually what that happens is one dominant follicle does not become dominant, or in my mind, I think of it as one follicle does not become the chosen egg looking for fertilization. So that mechanism is inhibited. The estrogen also inhibits the luteinizing hormone surge, and so it actually prevents ovulation. So it prevents that release of that egg, and so then the egg doesn't get fertilized. Now the other component is progestin, and you can see it's got 4 different mechanisms of action. So it also prevents ovulation. It also changes the endometrium. So if by chance that egg did get fertilized, it's harder for that fertilized egg to attach to the endometrius and be attached for the rest of the pregnancy. So it makes it more difficult. The progestin also thickens the cervical mucus, so it makes it harder for that sperm to swim up and meet with the egg. And then lastly, progestin alters fallopian tube secretions, and so it makes it more difficult for the egg or the follicle to be released from the ovaries and travel down to the fallopian tube. So you can see there's many mechanisms of action. Probably to be simple about it, we could tell a patient it's going to stop or prevent ovulation, because most females understand ovulation. We could talk about that it's going to change some of the secretions so that it makes it more difficult for an egg to get fertilized. But keeping it pretty simple, I think, would be better than this lengthy slide that we probably had to learn in pharmacy school. Now, the other thing that I want to point about the mechanism of action here is when you do have a combination contraceptive, when you have 2 components, it's the beauty of it, or the nice thing about it is if a patient, let's say they're taking a combination oral contraceptive, if they miss one pill, chances are they're not going to get pregnant because of all of these mechanisms that are in place at various times of the female cycle. So that's the beauty of it. Okay, so let's spend a little bit of time on combination oral contraceptives, since this is probably going to be the big chunk of what we would probably be dispensing. So we've got monophasic, we've got biphasic, triphasic, and now quadriphasic, I think is how you pronounce it. Now, when you think of the different phases, they are all equally efficacious. So if you pick one, it doesn't matter. If the female is taking it appropriately, then they're all going to be equally efficacious with a 97 to 99% contraceptive rate, if taken appropriately. Now, why were the different phases created? The monophasic was the first one, and you can see it has the same dose of estrogen and progestin, and for the most part, for the 3 weeks of the 4-week pill packet, for the most part, given a couple different exceptions of birth control pills. So then they're getting the same dose of estrogen, same dose of progestin. That's the most simplest product out there, comparing it to the different phases. The other phases were created in order to try to decrease some of the side effects, either due to the estrogen or due to the progestin component, or due to both. So you can see, like the biphasic, you could get different doses of estrogen, different weeks of the month, or 2 different doses of progestin, and it was just to try to decrease some of the side effects without losing any of the efficacy. And then same with triphasic. Triphasic was created to try to mimic more of the female menstrual cycle, where each week you have different doses of estrogen and progestin, and so trying to mimic that. But again, they're all equally efficacious, and so the Cochrane Collaborative Review recommends that it's the easiest way is to start with monophasic. And that's because since you have the same dose of estrogen and progestin, then if they experience any side effects, you know what dose, and usually you can tell what component, and we'll go over the side effects later as well. But monophasic is usually the easiest. So my guess is once we start dispensing, we're probably going to have maybe one monophasic or a couple monophasics, not the whole, the wagon of all the contraceptives that we have. Maybe a biphasic, maybe not. Maybe just one triphasic. You're not going to have a variety of them. You're just going to have to be familiar with a couple of them that you have at your pharmacy. So now on to picking doses for women. Well, it's recommended that we would pick a product that has an estrogen or ethinyl estradiol of 35 micrograms or less. And there are products out there that even have a lower dose of estrogen, like the 10 or 20 micrograms. And these, again, are still equally efficacious. So even though you go down on the dose of estrogen, you still do not decrease the efficacy. But chances are you might actually increase the risk of breakthrough bleeding, because breakthrough bleeding is usually due to not enough estrogen or not enough progestin. So that's the chance you take, is it might increase their side effects of breakthrough bleeding. However, it does decrease their cardiovascular risk, because eventually we'll talk a little bit more about this, of the estrogen is the component that increases the risk of the cardiovascular concerns. The estrogen is the one that increases the risk of MI, or heart attack, stroke, DVT, or deep venous thrombosis, or blood clots. So the estrogen's the component there. So getting something 35 micrograms or less is recommended because of that. But then the 10 or 20 could even decrease the cardiovascular risk even more. Now, there's only a couple products that actually have the higher dose of estrogen of 50 micrograms. And these are usually reserved for patients who are on anticonvulsants, such as the older ones, like the phenobarbital, phenytoin, carbamazepine, and those interfere with estrogen, and they inhibit that estrogen is no longer active. So the anticonvulsants, if someone's on those, it's recommended that you go a higher dose so that you have that higher dose to kind of compensate that drug interaction. Personally, if I saw a person on an anticonvulsant, I probably would refer them to a gynecologist and let them decide if the higher dose is an option, or maybe there's a different contraceptive altogether that might be a better option for someone who's on an anticonvulsant. Same is true for intractable breakthrough bleeding and persistent functional ovarian cysts. Those are areas where I would just let a gynecologist see the patient. They could still prescribe a birth control pill for them, but then they can assess it better, way better than I can. So I guess when I think about it, I would feel comfortable dispensing a product that's 35 micrograms or less and save the 50 micrograms for a gynecologist. So once we've picked an estrogen component, then we need to pick a progestin component. And we've got first, second, third, and fourth generations. And again, these were all discovered just to hopefully decrease the side effects that are attributed to the progestin. So for example, the third generation, which is desogestrel or negestamate, those are marketed for having less acne on the patient, having less hirsutism or hair loss, oily skin. And so women, those third generation were marketed to kind of decrease the testosterone type of side effects that are associated with the progestins. And then the fourth generation was identified that the progestin actually has a spironolactone analog. And the benefit there is that it would have maybe less swelling, less edema, and again, less androgenic activity compared to the first or second generations. So once we've identified a pill product, then we need to be able to explain to the patient how she's going to start taking it. So there's two different options. There's day one start and there's Sunday start. So day one start is that you would instruct the patient to take the first pill on the first day or within 24 hours of her menses. And then that product is going to be effective immediately, because I look at it as that pill packet is controlling or manipulating her menstrual cycle from day one. Versus if she wanted to do the Sunday start, you would instruct her as once she has started her menses, then the next Sunday or the first Sunday following that menses is when she's going to start taking the first pill. But because she hasn't started on the first day of menses, she's going to need backup protection for that first week. So backup protection would be condoms, spermicide, something like that, so that she wouldn't get pregnant, and you only need to have that coverage for the first week. The benefit that is perceived with Sunday start is that the menses would never occur on the weekends. Menses is usually going to occur that Tuesday, start into the placebo pill packet, either Tuesday or Wednesday, and then by the weekend it should be finishing the menses. And so that's the benefit of Sunday start. So let's talk about the advantages of the combination oral contraceptives. So probably the biggest one is that it decreases the menstrual flow, and it also decreases cramping, menstrual cramping. Since it decreases menstrual flow, then women are going to have less iron loss, and so less iron deficiency anemia is going to occur with those women. You can see all the other advantages. It decreases the risk of ectopic pregnancy, pelvic inflammatory disease, decreases ovarian cysts and cancer, endometrial cancer, a lot of different advantages, fibrocystic breast disease. It increases bone mineral density and decreases the risk of hip fracture. We already talked about the acne. And then there are products out there specifically marketed for decreasing the number of menses. And I've listed those as Seasonale and Seasonique, that instead of having a placebo week on the 4th week, that these placebo weeks are on the 12th week. So then women only have a menses 4 times a year. Probably one of the benefits that I've seen in some women are when if they do get headaches during their menses, that they would only get the headaches 4 times a year instead of monthly. Now with any drug, there's advantages and also disadvantages. So we need to talk about the disadvantages as well. Now the disadvantages, the top one that I think of is compliance. And we have these nice pill packets that remind women, that here's the Sunday pill, here's the Monday pill, and Tuesday pill. So you would think that they would be pretty easy to remember and follow. But, I've quoted in the handout that there was a study, and it's an older study, but I think it's still relevant because the pill packets really haven't changed. And in that study, it showed that only 42% of patients take the pill every day. And they describe that as, if they took it every day in that 24-hour time period. And if they took the pill every day, how many took it within 3 hours of when they were going to take it? So for example, since it's noon today, right now, I'm going to give the example of, let's say I take a pill every day at noon. If I was compliant, obviously I would take it every noon every day. But it's a 3-hour window. So 3 hours before 12 and 3 hours after. So sometime between 9 in the morning and 3 in the afternoon, I have to take my pill in order to be considered compliant. And so that's what the definition for this study was for these women. Based on that, only half the patients that said they take their pill every day actually take it within that 6-hour window. So definitely it's an area where we need to educate women to be more compliant. And I really don't have any good suggestions of how to help, except for pick a time that's going to work for them every single day, not only during the work week, but also on the weekends. The other disadvantages that are more risky in some aspects are the cardiovascular concerns. And these are all mostly due to the estrogen component. And in the handout, it goes through more tables of the risk of getting a blood clot or a deep venous thrombosis or stroke or myocardial infarction. And we have that data because prior to decreasing the dose of the estrogen, we used to have products that had ethyl estradiol of 100 to 150 micrograms per pill. And we know now that back in the 60s, women were more likely to have a stroke or a heart attack because of those higher doses. And so now that the products are lower, it's less of a risk, but there still is that risk. And so going through some of the risk factors that could put those patients at an increased risk, along with taking the estrogen component, is what we're going to have to try to figure out based on that questionnaire the female fills out, whether or not they're going to be a good candidate to be on a combination oral contraceptive. We know that estrogens increase triglycerides, so if someone had hypertriglyceridemia or triglycerides greater than 400, wouldn't be a really good candidate. And blood pressure, what most of the oral contraceptive companies are recommending is if they're uncontrolled hypertension. So they could be controlled as long as they're on an antihypertensive, then they could still be a candidate. It's the uncontrolled hypertension. And it's because, you can look in the handout, that estrogen can increase your systolic and your diastolic by about 20 to 40 millimeters of mercury. And it usually happens within the first 6 months. And so for us as pharmacists, once we place a patient on a contraceptive, having them come back every month and being able to check their blood pressure is going to be a really great advantage compared to when they were put on a birth control pill and maybe only go back to their physician maybe once during that time, if at all. I already said it's not going to offer any coverage of sexually transmitted infections. The benign hepatocellular adenomas were more based on the products that had the estrogen of the higher dose of the 100 to 150 micrograms. So it's in the package insert, but definitely a very rare concern for us to be concerned for. And then looking at the epidemiological studies that are numerous in the literature, the risk of breast cancer and cervical cancer, it just depends on which study you're looking at. Some of the epidemiological studies looking at combination oral contraceptives, it shows an increase of breast cancer risk, and then others show that it doesn't have any increased risk at all. And same is true for cervical cancer. So that's why I put the question marks there. That is going to be a tough question to answer for patients. And I think just explaining that there's many studies and there's many ways of looking at the data and whether or not it increases the risk or not. With that said, if a female already has a history of breast cancer or currently has breast cancer, and same with cervical cancer, they would not be a good candidate to have a contraceptive or oral contraceptive. Now this slide is the slide that is the contraindications, and this is what in some shape or form is going to be on the questionnaire that the female's going to fill out and answer. She's going to have to go down the list and make sure, has she ever had a history of any kind of embolic or thromboembolic disorders? Has she ever had a history of a blood clot? Has she had a history of a cerebrovascular accident or stroke? Has she ever had any heart attack or coronary artery disease? Any history of breast cancer? We talked about the different cancers. Any abnormal genital bleeding should be referred to a gynecologist. Any jaundice, any liver cancer, and if she's pregnant. So there's going to be those type of questions on the questionnaire to help us decide if they answer yes to any of these, then they would not be a good candidate for us to dispense a combination oral contraceptive. Now, what California has done is in their questionnaire, they even expanded on the cerebrovascular and the coronary artery disease definition, or to help them, help the patient really be able to identify, well, what would be at a risk, or what would be at a risk of a venous thromboembolism event or disease. And so this is an extended version from the questionnaire, from the California questionnaire. So it kind of goes into more detail to help the patient and help us decide whether or not, they would be a good candidate. So if they've had atrial fibrillation, they have any coagulopathies, again, the uncontrolled hypertension, diabetes with vascular disease, and any kind of migraine with or without an aura if they're over the age of 35. And the last one that I wanted to really make its own slide is the cigarette smoking. So any contraceptive agent is going to carry this box warning of if a person smokes 15 or more cigarettes a day and they're over the age of 35. So that "and" is important. That is in the box warning. Then they should not use any oral contraceptives. Now, with that said, in the clinic I'm in, we get some patients that maybe are not 35, but maybe they're 30 and they're heavy smokers. So should they be a candidate? And that's where the gray zone is. And I think each of us probably have to come up with our own comfort level of maybe we don't dispense to any smoker. Maybe that's going to be our policy, or maybe that's going to be the Michigan policy, or maybe it's going to be a heavy smoker plus over the age of 35. Maybe we put that age in there. Or maybe it's any smoking at all. Maybe it doesn't necessarily have to be 15 or more. And I think that's going to be determined as Michigan looks at the over-the-counter possibility. So the next thing I want to spend some time on are side effects, because definitely if we're dispensing this without a prescription, we are going to be the first ones that they come to and ask when they start having the side effects and what can they do about them. So we've got estrogen side effects and also progestin side effects. We've got estrogen if you get too much estrogen or not enough estrogen, and progestin, too much progestin or not enough progestin. So the first thing I want to do is focus on the estrogen. So if you have too much estrogen, or let's say you dispensed a product that is just too much estrogen for that patient, the side effects are going to be very similar to side effects that a female experiences when she's pregnant, because you have, during pregnancy, she has a lot of estrogen available. So the nausea, I think of that it would have the morning sickness or the nausea associated with that. That's due to too much estrogen. Same with bloating and edema, the hypertension, the migraines or the headaches, and then the breast tenderness. So that would be too much estrogen. So if you have a female that has started a pill product and within the first couple of months is saying, these are some of the side effects I'm having, then we could pick a product that has a lower dose of estrogen and she might be able to not experience those side effects. Now, the other side effects are due to not enough estrogen in that product. And usually I think of these as some kind of bleeding problem, either breakthrough bleeding, spotting, not a very heavy menses, which maybe is not necessarily a side effect. But if they have any kind of breakthrough bleeding or spotting, it's either due to a lack of estrogen Or you can see the next slide, a lack of progestin. So any kind of bleeding problem is going to be that they're not getting enough estrogen or progestin, and we need to figure out which product is it due to. I always think of early, let me go back, oops, early estrogen. So if they're having the side effects early during the pill packet, so that's defined as day 1 through 10, early means they need more estrogen or they are not getting enough estrogen during that time. So we need to pick a product that has a little higher dose of estrogen. If the bleeding or breakthrough bleeding or spotting is occurring during other than that, or beyond day 10, then that's considered late breakthrough bleeding or spotting, and that's because the progestin, you need to increase the dose of progestin or pick a product that increases the dose of progestin. Now, the other side effects are too much progestin, and how I try to remember that is progestin increases appetite, and with an increased appetite, those women are going to be more likely to eat more, and then they're going to gain weight. So the weight gain is usually associated with the progestins. And then the acne, like we talked about before, acne, oily scalp, hirsutism, hair loss, those are all due to the androgenic side effects of the progestin. Okay, on to drug interactions now. So there's a variety of different drug interactions, and there's some drugs that actually increase the efficacy of the oral contraceptive, or primarily increases the amount of estrogen. And although it's not really going to affect the efficacy, or we're not going to be concerned about efficacy, it could increase the risk of side effects or the cardiovascular concerns. So those drugs are listed there. But probably the one that's the more concerning is we need to know the drugs that are going to decrease the oral contraceptive efficacy and maybe potentially have a female have an unwanted pregnancy. So you can see there the anticonvulsants, like I mentioned before, those are probably the top in my list of the older anticonvulsants like phenobarbital, phenytoin, carbamazepine. You've got rifampin there. You've got theophylline, St. John's wort, which is concerning because it's over the counter. You've got a variety of different HIV medications, but personally, I wouldn't be dispensing an oral contraceptive to an HIV patient. I would probably refer them to their gynecologist and also their HIV ID physician. And then there's other ones listed there as well. But again, if a patient was on any of those, such as tacrolimus, I personally would want to refer them to their gynecologist. Now, if you notice, there are no antibiotics on the decreased efficacy list, and so you're probably wondering why, because if you went to pharmacy school, when I did, we were taught that you educate the patient of anytime that they're on an antibiotic, that would actually interfere with their oral contraceptive and potentially decrease the efficacy primarily of the estrogen. And you can see that in literature, the reported antibiotics have been the older antibiotics. So tetracycline, the erythromycins, penicillin, cephalosporins, and the proposed mechanisms of action, there's 2 of them. The first one is believed that it would interfere with absorption, that if you took an oral antibiotic, it would wipe out the gut flora, and that the gut flora or the intestinal bacteria is what is needed to activate the ethinyl estradiol to be an active drug or be active estrogen. Studies now have shown that it really is not a valid mechanism of action, that really the serum levels of antibiotics, when you're given a course of antibiotics, it does not affect the concentration level of estrogen or progestin as we once thought it did. So that mechanism is now falling to the wayside. Now, the second mechanism, though, is still a concern. The liver enzyme induction, primarily rifampin, is probably what we're going to have to worry about, and that it induces or accelerates the metabolism of progestin or progesterone and estrogen. And so that still is a valid concern where it would decrease the efficacy of the oral contraceptive. Based on the newer literature, the World Health Organization and also the U.S. medical eligibility criteria have both posted statements saying there is no restriction on the use of oral contraceptives with antibiotics, so that we no longer need to counsel those patients on the combination of or concomitant use of antibiotics with oral contraceptives. Now, with that said, there are still other organizations that have not changed their statement, and same with providers. They've not changed their counseling, and that they still are counseling using that they would recommend alternative contraception such as condoms or barrier method or spermicide for the length of the antibiotic duration plus another 7 days after that, just to make sure that that the patient doesn't have any decreased efficacy at all. And then the last slide of the drug interactions are what other drugs, what efficacy of those other drugs are affected. And so you can see that estrogen and potentially progestins will increase or decrease the drugs listed there. So that definitely could be a concern, especially when you see cyclosporins on there, warfarins on there, the thyroid agents like Synthroid or levothyroxine, and so on. So then to summarize, okay, so when we do the patient education, definitely talking about a dosing regimen of taking it every day, same time every day, and giving the patient the choice of either day one start or Sunday start, and explaining when that product is going to be effective for them. And then talking about missed doses, which we will talk about in just a second in the next slide. Going over the main side effects. Aches we will talk about, and again, no protection of STIs. So missed doses. This is an area where when you look at different package inserts of the different combination oral contraceptives, there is no one simple rule or explanation to tell for patients. So what I would recommend is that you be familiar with the missed doses section of each of your products that have the package insert of describing it. What I tried to do here is try to simplify as much as I could. So for example, if I miss one dose, so today is Wednesday, let's say I've missed Tuesday, what can I do? Well, you would tell me that today, whenever I remember, I would take Tuesday's dose, and that whenever it's time to take my Wednesday pill, that I would take it. So if I'm still taking it at noon, it is okay for me to take the Tuesday and the Wednesday pills together at noon. And since I only missed one pill, I don't need any backup protection. Where it gets a little tricky and messy is if I miss 2 doses, it depends on which week of the pill packet, and it depends on which brand you're talking about. But overall, if you've missed 2 doses during the first or the second week, so again, going back to my example, if I missed Monday and Tuesday, and now it's Wednesday, you are going to instruct me that today on Wednesday, I would take Monday and Tuesday today. And then tomorrow or Thursday, I would take the Wednesday and the Thursday pill. And then I would need backup protection for the next 7 days. So that is week 1 and 2. Now, if I miss 2 doses during the 3rd week, or miss more than 2 doses, then you're gonna instruct me to take the most recent pill as soon as possible. So let's say I've missed 3 doses. So I've missed Sunday, Monday, and Tuesday, and now it's Wednesday. You're gonna tell me to take Tuesday's pill and throw out the ones that I missed. So I'm gonna throw out Sunday and Monday. And then I will also have to use backup protection for 7 days. Now, the tricky part is, it depends on if I'm a Sunday starter or a day one starter of what you're going to tell me next. So if I am a Sunday starter, I'm just going to keep taking those pills like I normally do until the following Sunday. And then on Sunday, I'm going to throw out the rest, whatever's left, and start a new pill packet. If I'm a day one starter, then I'm going to take that missed pill that I missed Tuesday, throw out the rest, and start a new pill packet today. Very complicated, I think. Okay. So then, talking about aches is the acronym for abdominal pain, chest pain, eye problems, headaches, and severe leg pain. So, and those are warning signs that we want to instill in patients that if they have those, that they definitely need to be aware that those could be signs of a stroke, a heart attack, a blood clot, and that they need to seek medical attention just to be on the safe side. Okay. So we spent a huge time on combination oral contraceptives, but a lot of the concepts we will be able to apply to the various other products that we're going to briefly talk about. So the Ortho-Evra patch, you can see, I think of it as it's the size of 4 quarters. It's got an estrogen and a progestin, and the patient is supposed to put it on and leave it on for 1 week. And then after that 1 week, take that patch off and put on a new one and keep doing this for 3 weeks and then follow it up with 1 week where they're not wearing any patch at all. And that's going to be the placebo, or the equivalent to the placebo pills of the pill packet. Still have the option of the first day start versus Sunday start. You can see where they should be able to apply it or apply the patch in a variety of different places. And they should be able to swim and bathe and have water on the patch and not lose any of the adhesive. With that said, some patients that I've come across, the adhesive just doesn't really stick to their body for whatever reason. And so they just are not a really good candidate for that formulation. Another thing is some patients are going to be allergic to that adhesive. And so, again, they wouldn't be a very good candidate for that formulation. We do know that women who weigh greater than 90 kilos, we have seen that there is a decreased efficacy in this product. And remember, there's only one strength available. So again, might not be a good option for someone who weighs a little bit more. The one thing I think that sticks out to me with Ortho-Evra as the most concerning thing is this patch has been shown in studies that it's twice as likely to have a venous thromboembolism occur when compared to an oral contraceptive that has 35 micrograms of ethinyl estradiol. So that's a concern that we need to be aware of, is it could potentially increase the risk of DVTs, even at a higher risk than what we would consider of dispensing in an oral contraceptive. And then, the patient education of what happens if the patch falls off. If it falls off and it's been within less than 2 days or 48 hours, they can just reapply the patch. Otherwise, if it's been greater than 2 days or 48 hours, then they need to use a new patch, and that's when they need to use the backup protection for 7 days. Now, the unfortunate thing is sometimes, even if it falls off less than 48 hours, the adhesive may not be good enough to reattach. And you definitely don't want a patient to use, I've had patients describe to me where they've used duct tape or something like that to kind of help keep it on, and you don't want to have them do that because then that's going to increase the absorption, and so potentially could increase the risks of the cardiovascular risks and the side effects. So if the adhesive doesn't stay on, I just recommend using a new patch, even if it is within the 48 hours. And then, you could do the extended cycle where you put a patch on every week, and then on the 12th week, do a patch-free week. So then you have the extended cycle where you only have a menses 4 times a year. The other option that's available is a NuvaRing. And you can see, again, it's got a combination. So it's got the estrogen and the progestin component. This one is inserted vaginally and kept inside for 21 days or 3 weeks. And then it's removed, and you have a ring-free for 7 days, which is equivalent to the placebo pills of the pill packet. And again, if it's inserted on the first day of menses, you don't need any backup protection. And if it's inserted day 2 through 5 of menses, that's when you need the backup protection of condoms or spermicides for the next 7 days. Now, the disadvantage, I think, of with NuvaRing is, remember, there's only one size. And so one size is not going to fit all women. So it may expel out or come out it can come out during a bowel movement, it could come out during intercourse, or a variety of different scenarios. And so there's 2 different directions of what do you do when it comes out and when can you put it back in. There's the package insert and there's the CDC directions, and I have no idea why they are different. But the package insert says if it comes out within 3 hours, you just wash it with water and reinsert, and don't need to use backup protection. If it's greater than 3 hours, again, wash it with water, reinsert, but you need backup protection needed for 7 days, where the CDC, you can see, takes it out to 2 days or 48 hours. The one thing that we probably need to be concerned of is if the female has ever had a history of toxic shock syndrome, having this ring inserted is going to increase the risk of toxic shock syndrome for this particular patient. Okay, so briefly talking about progestin onlys. The advantage here is it only has progestin, so they may be at a decreased risk of the cardiovascular concerns, and you won't have to worry about the side effects related to the estrogen component. This is an area where in women that breastfeed, progestin-only contraceptives would be an option because since there's no estrogen, then the estrogen is what changes the quality and the quantity of breast milk. And so since you have a product that does not have estrogen, it won't affect breastfeeding or lactation. The disadvantage is since you don't have estrogen, you're deficient in estrogen. So you're going to have spotting, you're going to have amenorrhea, you're going to have breakthrough bleeding. So those are going to be the main side effects. The other thing is, remember, since you don't have all those mechanisms of action to help with the efficacy, even if a patient misses 1 dose, and it's defined as even if it's 3 hours late from taking the time or taking it when they were supposed to. So going back to my noon example, if I'm supposed to take a progestin-only pill at noon and I get home at 5 o'clock and go, oh, I forgot to take it to work, then I'm going to need backup protection of condoms or spermicide for the next 48 hours to be on the safe side. So even missing 1 dose. You can see there's less contraindications there, less drug interactions there, so there's definitely some advantages to the progestin-only contraceptives. And then patient education, again, talking about the dosing regimen of taking it every day, the compliance of how you're going to have to be very compliant or adherent to it, because even if you miss 1 dose, you're going to need backup protection. Side effects are only going to be the progestin-onlys, but again, no protection of STIs. All right, last product in this whirlwind here, Depo-Provera. So we know that it's an injection that you give either intramuscular or subcutaneous every 12 weeks. But there is a grace period. So what that means is, let's say I'm on vacation during the 12th week and can't come to the pharmacy. I could come week 13 or 14 and still get the injection and not have any loss of contraception. But if I come week 15, then I'm going to have to start all over, and I'm going to have to make sure that I'm not pregnant, and probably do a pregnancy test before we start with the Depo-Provera again. So grace period of 2 weeks. It's effective immediately if given the first 5 days of menses. Otherwise, again, that 7-day backup protection is recommended. It's got a low failure rate. Out of all the products that we talked today about, this one is the lowest because you only have to rely, the female only has to come into your pharmacy every 12 weeks. So we're not relying on her to take a pill every day or change a patch or whatever. Since it is only progestin, there probably is going to be no menstrual flow or cramping, or at least a very little amount of menses. Again, great option for women who are breastfeeding, and you could start giving it within 6 weeks of after they've delivered their baby. Again, since there's no estrogen, you don't have to worry about the side effects, although you still have to be concerned about the cardiovascular, the embolism, the heart attack or the MI or the stroke. And I think the reason behind this is this progestin is progesterone, and it's a very high dose of progesterone. And so it puts the patient at risk of those cardiovascular concerns, even though it doesn't have the estrogen component. Disadvantages are listed there. The biggest one is weight gain. Women are going to gain weight because, again, remember I said progestins increase your appetite, you're going to eat more, you're going to gain weight during the first 1 to 2 years. The other one that's concerning on this slide is that we now know there's an FDA box warning of that they recommend limiting the use of less than 2 years because since it's such a high dose of progesterone, that it actually has shown that bone mineral density is decreased, and that in the future, as these women are on Depo-Provera, we're probably going to see a higher incidence of these patients having osteoporosis later in life. So with that said, one of the big patient educations is making sure that they have adequate calcium and vitamin D. Okay, so with this whirlwind, I came across this cartoon that pretty much summarizes it. It's from Go Ask Alice. I will say there's some typos in this, which I could not fix since it's a picture that I just cut and pasted, but we'll go with it. So Alice says, what are birth control pills? Birth control pills are made of hormones. They keep eggs from leaving the ovaries. Pregnancy cannot happen if there is no egg to join with sperm. Very effective, works best when taken every day. That keeps the correct level of hormone in a woman's body. Advantages, you ask? Well, it's safe, simple, and convenient. It also improves your sex lives. It also helps acne, bad cramps, and heavy periods. Disadvantages include breast tenderness, nausea and vomiting, and bleeding between periods. How to purchase, you may ask? Well, you could get them at a Planned Parenthood, a clinic, a private health care provider, or I would add eventually a pharmacist. So with that, we are at 1 o'clock right now. And does anybody have any questions?
I will open up the lines now for questions, so you can either type them into the Zoom group chat, or I will unmute all of us. So please be mindful of your conversations if you are having them right now. So all the lines are all lines are unmuted. So go ahead and ask questions if there are any. Or you can use the chat box if you feel more comfortable with that.
I think I've bored you all to death. You're sleeping because you were eating lunch as well.
Can you clarify the question about transferring to a wholesaler or distributor regarding birth control pills? Your question on the quiz here?
Oh, let me look, because I put the questions, hold on. Because if I had time, we would have gone over. Hold on, let me see, because the questions are right after this last slide. Hey, I don't see the wholesaler thing though. The questions that I submitted were this one, a 23-year-old woman who had started on a combination oral contraceptive, was recently prescribed the anticonvulsant phenytoin to prevent seizures. Which of the following would be the drug interactions? So, is the oral contraceptive's efficacy going to be decreased, increased, or the anticonvulsant's efficacy increased or decreased? So, anybody want to answer that one?
First one.
Yes. Okay. The next question I submitted was this one. It's a 28-year-old female who was started on Orthonovum. She has breakthrough bleeding during her first week of her pill packet. The physician, or we could put the pharmacist, wants to change the oral contraceptive. What type of one should we prescribe? So the breakthrough bleeding is happening during her first week of her pill packet. So do we need a product that has an oral contraceptive with more estrogen, more progestin, less estrogen, or less progestin?
More estrogen.
Yes. And then the last one, which of the following statements is true for combination oral contraceptives? They may increase menstrual cramping, they may decrease bone mineral density, they may decrease blood pressure, or they may increase the risk of thromboembolism.
Increased thromboembolism.
Yep, you got it. Those are the questions that I submitted.
So we've got another one in there between the last one and the other one regarding the wholesaler or distributor on the list of questions that I received.
Yeah, I don't know that. Read that one to me, because I didn't submit that one.
Under the proposed revised general rules, the requirement of a wholesaler or distributor to be licensed would now prohibit a pharmacy from which of the following: selling or transferring non-controlled to another pharmacy, selling or transferring non-controlled medications to another licensee, selling or transferring controlled substances to another pharmacy, and selling or transferring controlled substances to another licensee.
I'm almost thinking, is that one of the questions from Dr. Behrens that she offered?
That might snuck in there when I updated my survey. I'll go in and fix it.
Okay, thank you.
So I have a question for you guys, if you don't have a question for me. So are people excited of the thought that we could dispense contraceptives, or does the thought, is it scary?
When did yours start? 1 o'clock? You can take over here. Just have Dave, are you using this? Oh, and that? Not the phone.
Are there any questions, or can anybody answer Dr. Bailey's question? If anybody is excited?
Or nervous to dispense them?
I would
Probably
think
all of the
would
above.
Yeah, me too, to be honest, yeah. And I think it will depend on what the legislature has. I think there's going to be some concrete things that we will be able to feel comfortable, if there's no contraindications, I'd feel very comfortable dispensing a product like that. But if there's any concern, I think I'm gonna refer that patient to a gynecologist, and I'm guessing there's going to be some upset patients of mine, but I think I'd feel more comfortable doing that.
Right. Okay.
Thank you.
Yeah, thank you.
Are there any other questions or comments for our presenter? Okay, if you don't have any other questions or comments, feel free to indicate them on your evaluation and I can pass them along to Dr. Bailey. And we'll go ahead and sign off for today. Thank you for joining us and have a great day.
Thank you.